So hello, everyone. I'm Javier Pinilla. I'm the Seymour Cancer Center in Tampa, Florida. I'm here today I have the pleasure to really have today with Dr. John Seymour from the Peter MacCallum Cancer Center in Royal Melbourne Hospital and University of Melbourne in Australia. And as you may know, Dr. Seymour is a pioneer in the development and clinical development of Venetoclax in the second line as well in the front line. And I have the real pleasure to have him today to discuss his ASH 2023 presentation on the Murano study, the response to subsequent novel therapies and time to second progression-free survival event in the Murano trial in patients with relapsed refractory CLL patient previously treated with this fixed duration treatment with Venetoclax plus rituximab. So how are you doing today, John?
Hi, Javier. Wonderful to be talking with you, and thanks for the opportunity.
Well, give us a brief, summary of the study you presented, and we can really chat about later on.
Sure, happy to. So, hopefully, I think most people will be familiar with the Murano study. So, as you said, in the relapsed, pre-treated context, and people were randomized to 2 years of venetoclax and rituximab. Hopefully now that's familiar. This is a study that led to the registration of that combination, time-limited combination in the relapse setting. Or people were randomized to then what was standard bendamustine and rituximab. Now, at the time, there were a couple of questions, and these still remain valid. One was, hey, BTK inhibitors are very good treatment for CLL. Gee, it looks venetoclax combination is very good for CLL. Do we know that we can safely go from one treatment to the other? Part of a sequencing question. And the other was, unlike BTK inhibitors, which are a continuous treatment, so when disease progresses while you're receiving a BTK inhibitor, retreatment with that BTK inhibitor with that same drug would not be effective. Whereas with time-limited treatment, you receive therapy, you stop, you have a period of time, might be short, might be long, and then disease progresses. Is it feasible to retreat with the same regimen? And so they were broadly the two questions that we examined here. Now, importantly, this wasn't the randomized portion. So we're looking at what occurred in the real life of these individuals. So for the sequencing issue, first of all, and I think in most centers, this would now be accepted and settled that you can effectively and safely go in either direction. Use a ven-based treatment first and then still with a BTK, or BTK first. But, we added this data. And so there were 23 patients who received ven-based treatment, their disease progressed, and then they went on to a BTK inhibitor. And they had an 83% response. Non-randomized, but that appears to be very similar what we would expect in a general relapsed refractory setting. And the median time to progression on that BTK inhibitor was 42 months, 3.5 years. Pretty good. So it adds to that body of data that using the drugs in that sequence. The second element, and to me, I think probably the more interesting element, was what about retreating with venetoclax? So you've had venetoclax, rituximab, you've got a pretty good response, you've stopped treatment, and then you go back on those same drugs. So there were 42 of those patients. Importantly, and we might come to discuss this because I think it's an area where we still don't have perfect information. For this group of patients, the median time off treatment was 30 months, so 2.5 years. So they've got 2 years of treatment, on average 2.5 years off treatment, and then receive venetoclax again. their response rate was 76%. 3/4 of patients got a second response. That's pretty good.
Very good.
Not everyone, but 3/4. And the median time to second progression event was 59 months. So they're getting, nearly 5 years of control with that second treatment. Now, this wasn't randomized. Some of them, the majority of them, got continuous Venetoclax treatment. Some got time-limited treatment. So it's a little bit of a variable group, but certainly my takeaways from that were that after a reasonable period of time after time-limited treatment, retreatment is very feasible, response rates are good, and subsequent disease control is very good.
Wonderful. So will you discuss also what's happened in I think it's quite interesting, but the point of view that obviously we have abandoned chemoimmunotherapy, but I think as you just well pointed out in the abstract, right, we don't have a lot of data, as you just pointed out, what's happened in the front line and the second line and so on. So we have patients who receive mostly, if not all of them, chemoimmunotherapy, and it seems that chemoimmunotherapy has an impact in the subsequent therapies, even with fixed duration of BTK. What is your thought about that?
Yeah, yep. So importantly, this study, as I said, it began recruitment 2016, 2015. So, a different era. And all of these patients had received chemoimmunotherapy in the front line or the second line. So perhaps in some parts of the world, different to what we're now seeing, where in many, many centers, people will receive a targeted agent up front. So this group, you might say, theoretically, may have worse biology because of mutations, selection for TP53, which was very prevalent here. So hopefully current groups will be less adverse. But for example, those who had received BR and then went on to receive Venetoclax, again, very high response rates, 90%, and going on to BTK inhibitors, response rates about 80%. So even where you were randomized to the BR, you can then salvage with subsequent targeted treatments. However, you do not make up for the full deficit. So there's still an overall survival difference of nearly 20% at 5 years. So my personal recommendation is, even now, if a patient had received chemoimmunotherapy in the past and they relapse even at 3 years or 5 years, maybe even 6, 7 years later, I would not, provided other drugs are available, I would not retreat with chemoimmunotherapy. I would certainly use one of the targeted treatments in preference. Again, different parts of the world, different funding, but if these are available. So we can then go to the targeted agents, but we do not make up all of that deficit. So bringing in targeted agents as early as is available in our jurisdiction, I think, is a very good thing.
Yeah, as you just discussing, right? Chemoimmunotherapy is still is being used in some part of the world where the access and the financial issues don't allow patients to really get that. So I think it still may be relevant for this population, but for sure we try to really introduce target therapies in the very, very beginning. So going the same theme, and I think something that, as you know, obviously completely not the study in the second line, but something that we discuss all the time in US forums, and I'm sure all over the world, is the data from the CLL13 in the front line, Venetoclax or venetoclax versus rituximab Venetoclax, really showing a very, very dramatic superiority in terms of MRD, PFS, and how this could have an impact on really the data on the relapse setting, as you may know, at least in the US, if the insurance approves, and I have to really admit that most of the time they don't really give us any trouble with introduction of Venetoclax. We prefer that, right? But what is your thoughts? I think it's something that most likely will never really have the answer, right? Because I don't think that this trial can be repeated. But what is your thoughts about substituting the Ovino with
Yeah.
the rituximab with Ovino.
I agree with you completely. So one of the key conclusions to me out of CLL13 is that obinutuzumab is a more effective partner with Venetoclax than rituximab. Clear. Now, that had been proven before with gentle chemotherapy. So chlorambucil obinutuzumab is more effective than chlorambucil rituximab in the front line. But it was necessary to prove that in the context of more effective targeted agents. But CLL13 has proven that. You're very fortunate in the US that your insurance will approve obinutuzumab, because in Australia, we don't have access. But as a clinician, I agree with your stance. And if it were available to me, I personally would prefer, even in the relapse setting, to partner with obinutuzumab with a few cautions. So the rate of infusion-related reactions is higher with obinutuzumab than with rituximab. So for some patients with severe cardiac or severe pulmonary disease, I'd want to be confident that I could safely deliver that. There is a higher rate of thrombocytopenia, slightly higher rate of neutropenia, about a 10% higher rate of grade 3+ infections.
I agree.
Using obinutuzumab than rituximab. So again, in all but perhaps the frailest patient, I'd prefer the efficacy benefit, but it does come with a slightly greater toxicity burden. Now that's all good and conceptual. What's the data proving that you can use obinutuzumab? The Jake Sumarai has a real-world efficacy paper looking at obinutuzumab in the relapse refractory setting that has just been published. That's very good. And there's the ongoing study, the REVENG, that Matt Davids is leading, and the German group that's formally evaluating the retreatment. So you receive, and so the data sets are accumulating, but I agree with your stance as a clinician. If it were available to me, with perhaps those few cautions or exceptions, my preference would be to use Ven-Obi in the relapse setting rather than Ven-Rituximab.
Wonderful, wonderful. Well, this is an excellent comment. So just to really finish, what are your thoughts about this dilemma that we really, have in a daily basis discussing therapies well with patients? I think the data you showed really are reinforcing the fact that really time-limited therapy with these targeted therapies is really efficacious, and even thinking that we can really doing this with second-generation monoclonal that, as you just pointed out, they have these caveats, fusion reaction and infection, but at the end they really produce deeper response. So what will be your message in general for patients who are really looking for these alternatives?
Yeah, I see it as a very positive and hopefully a very reassuring message. And importantly, that time-limited treatment, when disease recurs after that, people, both patients and clinicians, should keep open the option of retreatment. And so disease relapse does not equate necessarily with disease resistance.
Yeah.
And getting the greatest mileage out of each of these classes of therapies, here Venetoclax we're talking about, is really critical for our patient journey. So re-emergent disease does not necessarily mean refractory disease, and keep an open mind about utilizing agents and getting the longest benefit out of them.
Wonderful. I just want to really introduce something, because I remember these wonderful studies that you have done before in the Murano studies, showing who are the patient who has the shorter period of remission, right? And obviously, we're going to talk again to this high risk, genomic cytogenetics, complex cytogenetic TP53. Well, what are your thoughts about really time-limited therapy, continued time-limited therapy in the first, second line, in this more quote-unquote aggressive population of patient? Will be something, I mean, for sure it's feasible, but what is your thoughts on that?
Yeah. My personal preference with our current time-limited regimens, and I think one of the biggest challenges for us in the field is to improve and get better time-limited regimens.
Sure.
But with our current ones, my personal preference for patients with TP53 aberrant disease is to prefer a continuous therapy approach with a BTK inhibitor. For patients with IGVH unmutated disease, we recognize that time to disease regrowth and reemergence is more rapid after time-limited treatment. And here, knowing that, provided you have access in a funding, in an approval sense to retreatment, I'm very comfortable with a ven-based initial treatment. Some jurisdictions have a limitation on the number of times that you can use venetoclax-based treatment. And so, and this is probably an overarching theme for me, I very much take an approach, what are we going to do across the whole of the disease journey, rather than saying what's convenient in the next 6 months, 12 months, 2 years. And here planning, so if we use time-limited treatment, that's great, but disease may reemerge at 3 years, etc. And planning and having a strategy for what will we do again then. And looking, can we get re-access to time-limited treatment? If we can, I'm very comfortable using that. If in the regulatory setting, you only have one lifetime exposure to a venetoclax-based treatment, I would not use that up front in somebody with an IGVH unmutated disease. I would keep it for the relapse setting.
No, absolutely.
Complex karyotype is complex, and how much that plays out in the absence of TP53, I think we're still learning with targeted agents.
Well, absolutely. I will have to agree with you and with this statement. I think unmutated sometimes is been in the past kind of really pushed through the, treatment until progression. But as you guys very, very well know, and we have many patients that takes very long time until they really require therapy for the diagnosis, which in my opinion tell you something about the clonality, the clonal evolution of these cells. And obviously they can also compare with some of the mutated ones. So I don't think that all the patients are behaving the same. And definitely for sure is something that I offer to my patient in a daily basis too. Well, do you have any kind of final thoughts on the topic? Otherwise,
well,
I think at the end
really just to encourage our patients that the range of options continues to expand, encourage them to remain engaged in that discussion with their clinician, and convey what is important for them, what their own personal priorities are in terms of enduring treatment control, IV versus oral, time-limited versus continuous treatment, so that they're an active participant in that decision-making process.
Wonderful. Well, it's been a real pleasure to share your thoughts and the conversation about this study that you have presented. And thank you very much to share this with the audience in the CLL Society. Thank you very much, John.
Real pleasure, Javier. Thank you.